The subcommittee will come to order. The chair recognizes himself for an opening statement. Today we are marking up 6 bills: H.R. 1206, the Access to Professional Health Insurance Advisors Act of 2011, H.R. 6118, the Taking Essential Steps for Testing Act of 2012, H.R. 1063, the Strengthening Medicare and Repaying Taxpayers Act of 2011, H.R. 6163, the National Pediatric Research Network Act of 2012, H.R. 4124, the Veteran Emergency Medical Technician Support Act of 2012, and H.R. 733, the Recalcitrant Cancer Research Act of 2012. For the sake of time, I will highlight only 3 of these bills in my opening statement. H.R. 4124, the Veteran Emergency Medical Technician Support Act of 2012, introduced by Mr. Kinzinger, would give states demonstration grants to study how to better integrate military medics into civilian EMT jobs. During the legislative hearing on this bill in July, we learned that emergency response is a crucial component of our healthcare system. As EMTs are often the first point of contact in a crisis situation, their care can make the difference between life and death. Emergency response is even more crucial on the battlefield, where military medics respond to emergencies and provide care for the soldiers until a physician or other health professional can take over. These soldiers, trained as combat medics, become very experienced dealing with massive trauma injuries and other complex health problems. It seems that utilizing those with combat medic experience in our EMT workforce here at home would be good for the returning soldiers, good for the healthcare system, and good for patients. Next, H.R. 6163, the National Pediatric Research Network Act of 2012, will establish research networks and consortia that can address the unmet health needs of children, especially those with rare pediatric disease. Through my association with Children's Hospital of Philadelphia, I'm aware that there are too many diseases that children and their families face that do not have easy answers or adequate treatments. Since collaboration is so important to finding better answers, the funding of pediatric research consortia is a critical step. It will strengthen basic and clinical research and increase the number of researchers dedicated to finding new treatments and cures. Finally, H.R. 733, the Recalcitrant Cancer Research Act of 2012, will bring new hope to patients with cancers that have low survival rates. The bill will direct the National Institutes of Health to establish a scientific framework for the study of deadly cancers that sadly have not seen improved outcomes in decades. Working groups will be appointed to assist the director in preparing the framework that will include a review of current research and identification of unanswered medical and scientific questions and promising discoveries. The NIH would then be required to issue a report to Congress with recommendations on the effectiveness of the scientific framework model. Specifically, I want to acknowledge the efforts of Ms. Eshu and Mr. Lance on this important bill. I now recognize my friend from New Jersey, Mr. Pallone, for 3 minutes for his opening statement.
Thank you, Chairman Pitts. I'm going to keep my remarks brief. Today we're marking up 6 health bills in our subcommittee, almost all of which represent bipartisan efforts. They include H.R. 6118, the Taking Essential Steps for Testing Act of 2012, H.R. 1063, the Strengthening Medicare and Repaying Taxpayers Act of 2011, H.R. 6163, the National Pediatric Research Network Act of 2012, H.R. 4124, the Veteran Emergency Medical Technician Support Act of 2012, and H.R. 733, the Pancreatic Cancer Research and Education Act of 2012. These are all sensible and meaningful changes that I believe will have a positive impact on health policy and practice. Among these is the pancreatic cancer bill, which is personally important to me. I know all too well about the special challenges certain rare and deadly cancers face with respect to detection, diagnosis, and treatment, so I'm pleased to see that that bill in particular is moving forward. Unfortunately, H.R. 1206 remains a divisive bill and was a late addition to the markup calendar. This bill would amend the medical loss ratio provisions of the Affordable Care Act to the detriment, I believe, of health care premiums and consumers. I'm encouraged that my colleagues have finally come around to view the ACA as the law of the land and are trying to amend the law rather than repeal it. However, this bill doesn't amend the law for the better. Currently, the MLR requirement is working and putting downward pressure on insurance premiums as insurers with high administrative costs work to become more efficient. If passed, this bill would change that progress and instead drastically decrease insurers' accountability for spending consumers' premium dollars responsibly. When the National Association of Insurance Commissioners recently studied this issue, it estimated that carving out brokers from the MLR in the manner of H.R. 1206 would cut by 2/3 the amount of rebates consumers would receive. And I can't support a bill that would undermine a provision that is already yielding tangible results for consumers. And I yield back. Thank you, Mr. Chairman.
Chair, thanks, gentlemen. Now recognize the chairman of the full committee, Mr. Upton, for 3 minutes for his opening statement.
Thank you, Mr. Chairman. I'm pleased to see the Health Subcommittee moving quickly in the remaining days of the session to advance a series of bills with bipartisan support. I thank you very much. First, the subcommittee will consider the Access to Professional Health Insurance Advisors Act, a bipartisan measure that helps prevent some of the devastating consequences the President's health care law is having on small businesses that offer critical expertise to families and employers shopping for health coverage. According to a survey from the National Association of Health Underwriters, the new medical loss ratio mandate created in the health care law will force 21% of agents to downsize their businesses, resulting in fewer options for all consumers. So we know that this law breaks that promise that if you like what you have, you can keep it, and because of this mandate, it becomes harder to shop for a plan that you like and can afford. H.R. 1206 amends PPACA's medical loss ratio requirement to exclude compensation paid for licensed independent insurance producers from the premium portion of the MLR calculation. This common sense change will help small businesses that offer help to families and employers shopping for affordable health coverage to remain in business. We'll particularly want to thank Mr. Rogers and Mr. Barrow for taking the lead. Second, the subcommittee will consider H.R. 1063, the Strengthening Medicare and Repaying Taxpayers Act, or SMART Act, introduced by Dr. Murphy. This bill creates efficiencies in the Medicare secondary payer program that benefits taxpayers and seniors alike. During last year's hearing, several flaws in the program were identified that resulted in seniors losing Medicare coverage and settlements and ending up in escrow. So this makes improvements to that bill. That's a very good step in the right direction. I also particularly want to thank Ranking Member Waxman for working in a bipartisan manner to present H.R. 1063 to the committee today. We've got some additional work to do before we get it to the full committee, but I certainly plan on working with him and Dr. Murphy to resolve those issues. Subcommittee will also consider H.R. 6118, Taking Essential Steps for Testing Act, which gives the Centers for Medicare and Medicaid Services much-needed regulatory flexibility to laboratory certification. And for many Americans who have been diagnosed with a hard-to-treat cancer, H.R. 733, the Recalcitrant Cancer Research Act of 2012, offers great new hope. Some cancers, such as pancreatic cancers, have had few significant improvements in diagnosis and treatment. This bill will guide efforts at the National Cancer Institute by identifying a scientific framework that will focus and guide research efforts and advance the search for treatments. And I want to say a special thanks to Ms. Eshu and Mr. Lance for their very good work on this legislation. Lastly, the Veteran Emergency Medical Technician Support Act will help military EMTs to transition to civilian service. Again, 6 bills before the committee. I appreciate the hard work of the subcommittee and yield back my time.
Chair, thanks, gentlemen. Now recognize the gentleman from California, Mr. Waxman, for 3 minutes for his opening statement.
Thank you very much, Mr. Chairman. Today we're going to mark up 5 important health bills in which we've reached consensus. Unfortunately, we're also considering a bill in which we do not have agreement. H.R. 1206 exempts agent and broker commissions from the medical loss ratio consumer protection created in the Affordable Care Act. In passing the ACA, we took a number of steps to hold down premiums, which had been rising by double digits between 2000 and 2010. The ACA requires insurers to publicly justify high premium rate increases, and according to a report released just this morning, this provision has saved Americans more than $1 billion. The ACA creates a fair and transparent marketplace in 2014 where premiums will not be higher for people with pre-existing conditions. The ACA requires insurers to spend 80 to 85% of premium dollars on benefits and quality improvements, limiting administration, marketing, and profit, or pay families and businesses premium rebates. Nearly 13 million Americans have received a total of $1.1 billion in premium rebates because of this provision. H.R. 1206 weakens this third protection, called the medical loss ratio requirement, by exempting from the calculation agent and broker commissions, essentially allowing more spending on administrative costs and increasing premiums. Agents and brokers play an important role in the health insurance market, and they will continue to do so, helping millions of new customers under health reform. The current medical loss ratio requirement benefits consumers while leaving adequate room for agents and brokers to be reimbursed. Exempting such commissions without increasing the MLR puts more money in insurers' pockets, effectively weakening the standard and reducing premium rebates for families and businesses. Importantly, it asks consumers to foot this bill. Even though I oppose the bill, I'm pleased that my Republican colleagues finally have given up their endless effort to repeal every provision in the Affordable Care Act and are engaging in a substantive discussion of its provisions. That's a step in the right direction. Another step in the right direction is our bipartisan effort on the 3 public health bills we'll consider today. Collectively, these bills will, 1, provide assistance to our returning war veterans with emergency medical training. 2, provide specific authority for NIH to establish a network of pediatric research centers. 3, require the National Cancer Institute to focus specifically on recalcitrant cancers. I also support 2 bills that build on the long history of work of this committee: the Clinical Lab Bill, H.R. 6118, the Medicare Secondary Payer legislation, H.R. 1063. The goal of that bill is to reduce the burdens of secondary payer processes for beneficiaries and other stakeholders, but to do it in a way that makes sure that we're protecting taxpayers' dollars and the Medicare Trust Fund. I appreciate the Chairman's willingness to work with us to achieve a bipartisan solution. Congratulations to our various colleagues who led on each of these worked out bills on both sides of the aisle on a job very well done. Yield back my time.
Chair, thanks, gentlemen, and now recognize gentleman from Pennsylvania, Dr. Murphy, for 1 minute.
Thank you, Mr. Chairman. On H.R. 1063, 4 years ago, Lorraine Babbage of Washington County in southwestern Pennsylvania, then age 73, suffered injuries so severe in a car accident that she will never fully recover. After surgery, Lorraine contracted MRSA from her rehab facility, and her condition has worsened, and she now suffers from dementia. She must receive 24/7 care at a nursing home. The physical pain in Lorraine's life is multiplied by the emotional pain of recent years. A year after the accident, Lorraine lost her husband, and then last year, her only child passed away. Lorraine's story is heartbreaking and tragic, and it's depressing to learn Medicare is working against Lorraine's interest. In the fall of 2010, Lorraine's attorney and the automobile insurer representing the individual who caused the accident reached a monetary settlement. Lorraine would receive damages, and the insurer would pay her medical bills. But since that time, the parties have repeatedly asked CMS how much is owed to the Medicare Trust Fund. The insurance company wants to make Medicare whole and repay the money they spent on medical expenses and provide Lorraine with a settlement, but CMS's complicated bureaucracy is in the way. Under the Medicare Secondary Payer Statute, insurers must repay Medicare if their policyholders' negligence led to medical bills for a senior citizen, but the current system is complicated and riddled with bureaucratic delays, and the bipartisan SMART Act, or the Strengthening Medicare and Repaying Taxpayers, fixes these problems, recoups billions of dollars owed insurance companies to the Medicare Trust Fund, helping people like Lorraine. I do want to make sure I thank Chairman Pitts, Ranking Member Pallone, Bob Horn, the staff, Brian Cohen, and Mr. Waxman for all their hard work. Without that help, this legislation wouldn't be moving. There's a couple minor issues to resolve, but I'm confident we can overcome them before we reach the full committee. And with that, I yield back.
Chair, thanks, gentlemen. Now recognize the gentleman from Michigan, Mr. Dingell, for 3 minutes for his opening statement.
Consent to revise and extend my remarks. Thank you, Mr. Chairman. I'm pleased to see that we're engaged in bipartisan legislation. The bills before us prove it is possible to work together for the good of the American people. Together, we can provide our veterans who gained EMT training in the military, who have selflessly given of themselves the opportunity to seamlessly transition to an EMT job in their home country and to bring skills to the society that are valuable and important to us. Today, we're also working to give hope to the hopeless, those with cancer such as pancreatic and ovarian cancer that have mortality rates much too high and survival time much too short. We will ensure that the research is being done by the National Cancer Institute to eradicate or to eliminate these killers. We're also working to make sure Medicare's secondary payer system is streamlined with common sense legislation. For example, Medicare will not try to recoup money worth less than the cost of the recovery process. I'm also happy to see my good friends on the other side are no longer trying to take apart the Acceptable Care Act. I hope that this is something which will persist. My Republican colleagues, I hope, have finally accepted after some 30-odd attempts to repeal that it is a law whose benefits have been and will continue to be implemented that are willing to work to improve it. Unfortunately, H.R. 1206 is not the way to do it. The medical loss ratio was created so that our constituents' hard-earned dollars go towards the highest quality health care instead of administrative costs. The MLR has now achieved this. Most insurance companies now apply between 80 and 85% of the premiums towards health care and between 20 and 50% towards administrative costs. Interestingly, Mr. Chairman, over 100,000 people in my state of Michigan are receiving rebate checks for $200 or more because their insurers have not met this logical standard. It's important to continue to maintain this level of efficiency and to direct the flow of premium dollars towards improving the health care of our nation. Let us remember at the end of the day, it is always our constituents that matter the most. I yield back 30 seconds.
Chair, thanks, gentlemen. Now recognize Dr. Burgess for 1 minute for an opening statement.
Okay.
Go ahead. Mr. Lance, 1 minute.
Thank you, Mr. Chairman, and I want to thank all of those involved. I understand there will be an amendment in the nature of a substitute on H.R. 733. This relates to the fact that we have together worked on the Recalcitrant Cancer Research Act of 2012, and I want to thank all of those who've made this possible, including Congresswoman Eshoo and you, Mr. Chairman, and Ranking Member Pallone. Thank you.
Chair, thanks, gentlemen. We are out of time on the floor. We need to go to vote. So at this time, we will recess to vote, and the markup will reconvene 10 minutes after the last vote, which should be around 2:50. The subcommittee stands in recess. All right. Recess having expired, the chair calls up H.R. 1206 and asks the clerk to report.
H.R. 1206, to amend Title 27 of the Public Health
Without
Service
objection,
Act.
the first reading of the bill is dispensed with. The bill will be open for amendment at any point. So ordered. Does any member wish for time? Chair recognizes gentleman from Michigan, Mr. Rogers, for 5 minutes.
Thank you, Mr. Chairman. I appreciate your work, your effort. I want to thank Chairman Upton as well for allowing this bill to move forward. And it is an incredibly important bill, and I think highlights one of the many problems with the Affordable Health Care Act that has cost real people their jobs, and it's happening today. Some 75,000 jobs we know from just this one provision that in a very bipartisan way, some 23 Democrats have signed on to the bill because we have all acknowledged this is just really does not pass the common sense test about how we move forward for taking care of Americans. You know, the folks who we're talking about, according to the Bureau of Labor Statistics, have an average income between $45,000 and $62,000 a year. Now, they're agents, and they're the ones that are in our local communities and working with small business, trying to decipher what was a complicated healthcare business before, who is, after the passage of the Affordable Health Care Act, is almost incomprehensible to those small businesses now. And at that very time, you have cut these folks' wages, or incomes, by 70%. 70%. It's not sustainable. So we know that these folks are losing their jobs. I have a couple of testimonials here quickly. I'll just go through a couple of them. The MLR rule makes it next to impossible to continue my mission to make a difference and still make a living, an agent from Kansas. If there are no changes to the law, there is a strong possibility we will be out of business, affecting at least 8 employees, an agent from Boise. I don't think agents or brokers have a fighting chance in this environment. We'll take a 30 to 70% cut in income with no end in sight, an agent from the Bronx in New York. Our clients rely on our firm to help them determine the proper coverage and to help them with claims. To think that we can continue to do the same with drastically reduced compensation is ridiculous. An agent from Adrian, Michigan. I have already been let go from my agency, and now I am on my own trying to make income to support myself. The commission level has been cut by at least 50% or more, and I still work just as hard. Clients need the help. They are more confused than ever with all the new laws. An agent from Illinois. This has had a tremendous negative impact on 2 fronts. One, are individuals, that middle-class American from $45,000 to $65,000 a year trying to take care of a family. They are getting crushed by this today, absolutely today. This isn't 2014. This isn't in the future. It's today. These people are losing their jobs. That in and of itself should be the reason we pass this bill as quickly as we can. Secondly, you have all of these small businesses in America that we all say that we champion, who are dying for information on how to navigate through a very confusing law that has already risen premiums since the passage by $2,000 per plan. $2,000 per plan. This is exactly the time that you need somebody who does this for a living, can help you navigate those plans and make the best decision for you and your employees so they can get health care coverage. We could talk a long time about this, but I just want to reiterate it is a bipartisan bill, no divisiveness here. 23 Democrats have joined us because of the impact to average Americans in our communities who are losing their jobs and not able to provide the services for a very confused small business community trying to navigate what they need to do to take care of their employees when it comes to health care. And with that, Mr. Chairman, I again thank you for taking up this important bill, and I yield back the remainder of my time.
Chair thanks the gentleman. Anyone's chair recognize gentleman Mr. Plone for 5 minutes to strike the last words.
Thank you, Mr. Chairman. I'm pleased to see this committee has come to its senses and we have finally moved beyond bills that merely repeal entire sections of the Affordable Care Act. However, H.R. 1206 is a bill I can't support because I believe it weakens one of the most important and popular insurance reforms in the ACA, and that's the medical loss ratio requirement. The medical loss ratio requires that insurers spend at least 80 to 85% of your health insurance premium on benefits and quality improvement activities. At a time when insurance premiums were rising by the double digits yearly, this reform put pressure on insurance companies to spend wisely and get value for every premium dollar. And because agents and broker commissions are often set as a percentage of premiums, their commission increased with premiums, and many brokers were generating twice as much revenue in 2010 as they were in 2005. But I believe that if we were to lower health care costs, everyone needs to be a part of the belt tightening, and that means not just providers in the government, but also insurers and brokers. So when a family works hard to secure and pay for their health insurance, they have every right to expect insurers are providing them value, and the ACA now requires that value. Now, I know today will likely be filled with a lot of misinformation, so I wanted to set the record straight. First, consumers have saved over $2 billion on health insurance premiums since the passage of the ACA because of the medical loss ratio and rate review consumer protections that finally prioritize consumers. H.R. 1206 will increase health insurance premiums. Agent and broker jobs increased, not decreased, by 7,000 since May of last year and by 3,100 since this past May, while the medical loss ratio consumer protection was in effect, according to an impartial Insurance Information Institute. So H.R. 1206 does nothing to guarantee any new agent or broker jobs, but it does benefit insurers at the expense of consumers. Nearly 90% of insurers today are meeting the current medical loss ratio consumer protection, as agents and brokers continue to operate. But H.R. 1206 weakens the standard that nearly all insurers can already meet, allowing them to increase salaries, profits, and other administrative costs. 7 states received an adjustment to lower the 80-20 medical loss ratio requirement in their individual market after balancing the insurer's inability to meet the rule and the price of health insurance for consumers. Other states could not provide data supporting an adjustment. But H.R. 1206 would have reduced the $1 billion consumer premium rebates by at least $360 million, increasing premiums for 3.8 million people in Delaware, Florida, Indiana, Kansas, Louisiana, Michigan, North Dakota, Oklahoma, Texas, and Wisconsin. Nearly 13 million Americans have received $1.1 billion in premium rebates because their insurance company failed to cap their administrative spending on things such as salaries, profits, and marketing at 15 to 20% of premiums. But H.R. 1206 would reduce premium rebates by 60%, according to professional staff at the National Association of Insurance Commissioners. In fact, my own staff received one of these rebates because her insurance company didn't spend 80% on her medical care. And I bet more people in this room can say the same thing. So the medical loss ratio is working. The sky isn't falling. Agents and brokers have and will continue to have an important role to play in the health insurance market. In fact, they'll have an even bigger role once millions of new consumers, or customers, I say, have access to health insurance under the health reform bill. And I simply believe this bill is unwarranted and is only going to hurt consumers, Mr. Chairman. So I'd urge my colleagues to vote no on H.R. 1206. I yield back.
Chair, thanks, gentlemen. Recognize the gentleman from Georgia, Dr. Gangry, for 5 minutes.
Mr. Chairman, thank you very much. And I want to commend Mr. Rogers for 1206. Of these 5, 6 bills that we're marking up in a bipartisan way, and I agree with my colleagues on both sides of the aisle, that's a good thing. I feel like this probably is, if not the most important of the lot, it's certainly one of them. The issue of medical loss ratio at 85% for the large health insurance companies, 80% for the smaller ones. I don't know how many health insurance companies are across the country, probably 1,300 or so, is a good concept. And my friend from New Jersey just said, well, you know, to keep these companies from excessive profits, spending money exorbitantly on marketing, salaries that are over the roof, golden parachutes. There was an article several years ago about CEO of one of the larger health insurance companies who came from the medical provider space. I forget the person's name, but that's not important. But, I mean, his salary was like $18 million a year with a golden parachute. Now, those are the things that we're talking about in regard to limiting money spent other than for patient care. But when you're talking about, as the anecdotes that Mr. Rogers presented, I've got some myself, we all do, of these small independent insurance agents, indeed in some cases brokers. I spent 4 years on a local school board back in the early 90s, and we utilized a health insurance broker to evaluate all these plans that were brought to this 10,000 student school system in the city of Marietta to make sure that those employees were going to get the best health care plan for their dollar, the best bang for the buck. And in the long run, this is about health care, because if they get the wrong policy, maybe just because it's a little bit cheaper, but it doesn't give them what they need when they need it. And again, I mean, the amount of the $1 billion worth of rebates and savings, I mean, that had to do probably more with these big health insurance companies not being able to justify a premium increase. I'm all for scrutinizing that very carefully, but don't throw the baby out with the bathwater. And quite honestly, I'm really surprised that my colleague from New Jersey, the ranking member emeritus, the people with the most experience on this committee, the smartest people on the other side of the aisle here, would resist something like this that clearly is a common sense provision that never should have been in the first place, because this is about health care, the advice from these experts. And these are not the people making $18 million a year, as the gentleman from Michigan pointed out. So I think this is a great bill. It's common sense. It makes sense. And I know we have good support on the other side of the aisle. I'm just surprised that it's not from the leadership over there, and it's not unanimous. And with that, I'm going to yield the rest of my time back to the author of the bill, Mr. Rogers. Anybody else on our side of the aisle wish to utilize any of my time? If not, Mr. Chairman, I'll yield it back.
Chair, thanks, gentlemen. Chair, now recognize the ranking member, Mr. Waxman, 5 minutes to strike last.
Thank you, Mr. Chairman. I am impressed by Mr. Gingrich saying he doesn't want to throw the baby out with the bathwater. That's what we've been saying what Republicans would do if they just repeal the whole Affordable Care Act, a lot of which they say they agree with. Even Mitt Romney said he agrees with some of it.
Well, with all due respect, that's a little bit beside the point.
Point of order, Mr. Chairman. It's my time, and I don't think it's appropriate for the gentleman to talk over me during my time, just because he may disagree with me. Governor Romney said he agreed with some of the things in the Affordable Care Act. His campaign then said he didn't really mean that. I don't think we ought to throw the baby out with the bathwater either. That's why I support the Affordable Care Act, and when it's appropriate, we can make changes to it. But I don't think this is an appropriate change, because one of the best features of the Affordable Care Act is the requirement that most of the money, the overwhelming amount of the money, go to services, not to overhead. And that medical loss ratio requires insurers spend at least 80 to 85% of consumers' health insurance premiums on benefits and quality improvement activities. But this bill undermines that provision. Now, I'm sympathetic to the agents and the brokers, people who do serve a very important purpose, and they are entitled to compensation, but their compensation ought to come within that medical loss ratio, just as the insurance companies will want to have these brokers and agents steer their clients to them. Between 2000 and 2010, employer health insurance premiums rose 114%, from $6,400 to $13,800 for the average family. At the same time, total agent and broker commissions in California alone went from $5.8 million in 2000 to a stunning $168 million in 2010. How could that be? Well, a lot of the agents and brokers had a percentage of the premiums. So as the premiums increased, commissions increased. And and partly because commissions percentage increased, particularly in the individual market. The medical loss ratio is important. People are getting rebate checks. They're delighted with the fact that the money is going to go for services and not for more overhead. Within that amount, I think the agents can get their due compensation. But this bill would weaken that medical loss ratio by exempting from the calculation agent and broker commissions, effectively allowing insurers to keep even more dollars for profits, salaries, and administrative costs, leaving consumers holding the bag for higher premiums. We're asking everybody to tighten their belts. Insurers will benefit by effectively having a less stringent medical loss ratio, allowing higher profits and less in rebates to consumers. The NAIC's professional staff said it would have effectively eliminated 60% of the rebates to consumers in a small business, and we can... I don't know how you do this. Does anybody know how to turn this off? But we ought not to go along with it. Why would we weaken something that 90% of insurers can already achieve? Nearly 90% of insurers are already meeting this medical loss ratio, so why increase the amount that can come out from that medical loss ratio? According to the NAIC's professional staff, the exemption would also effectively eliminate 60% of the rebates. Insurers have the leverage and positioning to ensure the best value for agents and brokers' commissions, not consumers. And so the consumers would end up paying a lot more for the agents, and that'll all come out of that medical loss ratio. So I don't think we ought to agree to this bill. I'm sorry if it shocks the gentleman from Georgia, but I disagree with him. Consumers have been put at the front of the line for value over a decade of double-digit premium increases. Let's keep the consumers in mind and lower that medical, allow the medical cost ratio to stay as it is in the bill. I yield back the balance of my time.
Chair, thanks, gentlemen. Now recognize the gentleman from Louisiana, Dr. Cassidy, for 5 minutes.
Somehow this seems apropos. Benjamin Disraeli said there's 3 types of lies: damn lies, and statistics. And so the thought occurs to me, if you just look at the medical loss ratio, it sounds so nice in concept, but in reality it prejudices against the lower cost policy. If you look at health savings accounts as an example, health savings accounts, very low cost relative to other products, so low cost that the medical loss ratio, that 15% administrative cost, is a mere pittance. If you will, by not allowing someone to market that, because frankly there is no money to pay for marketing, we are removing the ability for these products to be offered to the general public. Contrast that with the very expensive bells and whistles policy, in which it's 15% of a very high absolute amount. You can pay for a broker's commission, you can pay for all the Obamacare taxes, you can pay for the Obamacare paperwork, you're going to pay for all of the Obamacare stuff, because the absolute cost is so high. If you will, that kind of smooth argument that Mr. Waxman just gave is really an argument for higher cost policies. Now, let me also then move on to the value that I think the broker brings to the decision. If you will, when a small businesswoman purchases a policy, she's not just purchasing the policy, she's purchasing the service of the policy. My dad sold insurance. I once asked, Dad, how come people just don't call up and get their policy? This was when I was 15 years old. My father said, if you think that small businessman, with so many things that he has to address, is going to be able to track down a single claim for one of his employees, you don't understand the pressures they are under. Now, my dad didn't sell health insurance, he sold life insurance, but I remembered that many years later. If you will, what we're saying with this is that we don't trust the market to put a value upon the service that that broker brings to the small businesswoman or small businessman, and we want to prejudice the insurance company to offer a higher cost price. Whenever someone tells you that central planning is a more effective, efficient allocator of resources than is the marketplace, it brings back Benjamin Disraeli's quote. I yield back.
Chair, thank the gentleman. And the chair recognizes the gentlelady from Illinois, Ms. Schakowsky, for 5 minutes.
Well, despite what the gentleman said, the National Association of Insurance Commissioners unanimously voted in 2010, maybe they're just all full of damn lies, to recommend a medical loss ratio formula to HHS that counts agent and broker commissions as part of an insurer's administrative costs, and it was approved by every single state commissioner, including the District of Columbia. And further, the professional staff at the NAIC said that if agent and broker commissions had been removed from the medical loss ratio calculation, it would have eliminated 60% of the rebates to consumers based on 2010 data. Now, in Illinois, almost 300,000 Illinoisans received almost $62 million in rebate due to the MLR requirement. That's a lot of money to a lot of divided among a lot of people, but significant nonetheless. Almost 12.8 million Americans received more than $1.1 billion in rebates from insurance companies that failed to meet the MLR requirement. And applied to the 2011 data, consumers would have received almost $660 million less in MLR rebates this year, but would not have had any additional medical care or quality improvement initiatives in return for those premium dollars. Frankly, I think that excluding agent and brokers' commissions, as this bill would have us do, would be a handout to insurance companies who would effectively have a less stringent MLR requirement that allows for higher profits at the expense of consumers' hard-earned premium dollars. The intention of Obamacare was to give consumers value for their dollars. And while agents and brokers play an important role in helping American consumers and businesses purchase health insurance, their compensation should come out of the 15 or 20% of premium dollars reserved for administrative and other costs. I think to argue otherwise about what is an administrative cost it just contradicts the facts, the obvious facts. HHS has determined that the Affordable Care Act has saved over $2 billion for consumers in premium payments, $1 billion as a result of the rate review that we put into the legislation, and $1.1 billion in medical loss ratio rebates. The other thing is, if we look at the effect on jobs, according to the Insurance Information Institute, employment for agents and brokers has actually increased since June 2011 by 7,000 jobs. So if it weren't a good business to go into, you couldn't make money, people wouldn't be going into it. I already reported that the NAIC supported this unanimously. I think it's good policy, and that this legislation backs up on what the legislation, which I proudly call Obamacare, has done to provide affordable, quality health care for all Americans. And we've already begun to see those results. We shouldn't take those away. This is part of the piecemeal effort on the part of the Republicans to take away the benefits that have already accrued to consumers, and I think we should vote no and vote yes for consumers by voting against this legislation. Thank you. I yield back.
Chair thanks, gentlelady. Now recognize the gentleman from Ohio, Mr. Latta, for 5 minutes. Strike the lights. Word.
Thank you, Mr. Chairman. I'll yield to my friend, Mr. Gingrey from Georgia.
Mr. Chairman, I thank the gentleman for yielding. My colleague from Illinois just talked about the National Association of Insurance Commissioners. Maybe after this markup we need to get together and compare notes, but I've got information that's strikingly different from that. Maybe it was after they approved the idea of a medical loss ratio limit of 85 and 80%, but agent commissions are never part of an insurer's actual revenue, and we feel, and that's what this bill is all about, they should not be counted as an insurer administrative expense for the purpose of calculating the MLR ratio. And this has been confirmed. Let me say that again. This has been confirmed by the National Association of Insurance Commissioners, the nonpartisan experts on state insurance markets. I would suggest, I will in just a second. I would suggest that had the Democrats in the majority in Kraft and Papaka, if they had taken the opportunity maybe to talk to their own members, their rank and file members who came maybe from the health insurance space in their prior life as either agents or brokers for health insurance, they probably would not have included that as part of the calculation if they had just simply listened. They didn't listen to anybody on our side of the aisle. We know that. And the gentleman from California, the ranking member, wanted to bring up the whole issue of, well, whether it's trying to chip away at the provisions of Papaka. I mean, you get the old pride of ownership suggestion that, look, we came up with the perfect bill, and don't you dare try to change it. No bill is perfect. And this clearly, I mean, I'm shocked that they can't see that this was an oversight that just needs correcting. With that, I'm going to yield to back to the gentleman from Ohio, who I think will be yielding to the gentleman from Michigan, the author of the bill.
Mr. Chairman, I yield to Mr. Rogers.
Thank you, Mr. Latta. And to my good friend from Illinois, I just want to read from the resolution from the NIAC, of which you quoted a study, not a resolution, in 2010. Quote, "We are very concerned about the impact the MLR requirement could have on the ability of insurance agents and brokers to continue assisting health insurance consumers at a time of rapid changes that makes their role even more essential. Congress should expeditiously consider legislation amending the MLR provisions of the PPACA in order to preserve consumer access to agents and brokers."
Would the gentleman yield when?
Yeah, can I finish the quote?
Yeah, sure.
Yes, ma'am. And HHS should take whatever immediate actions are available to mitigate the adverse effects of the MLR rule. So I think they're quoting an old study, not a resolution. The resolution after the bill was enacted clearly states the NAIC's opposition to it, number one. Number two, the 75,000 job loss comes from the folks who are actually in the business of trying to employ these people. That is a real number and real loss and impact on real families. Yeah. The $1.1 billion my friends talk about repeatedly, great, it's all wonderful and good. The only problem is that works out to about $100 per plan recipient, and the increase alone in their premiums because of the bill was $2,000. Now, that math may work in your family budget, but I'll tell you what, I'd take that $2,000 over that $100 check at the end of the year any day of the week. That's real money to middle-class Americans, $2,000. How are they going to keep their health care plans? No idea. That is huge amount of money to the average working American who's, and by the way, the brokers themselves who also pay these higher premiums, these are people who are making $45,000 to $62,000 a year. That's what we're talking about. We ought to be able to, without pride of authorship, go back and say this is the right thing to do for these people who are trying to provide a service to a very complicated health care law.
Mr. Rogers, can I have a few seconds?
I would yield the... Well, I don't know if I can do that. Mr. Latta, I think, has to do that. But I'll yield back to Mr. Latta to yield to you.
Thank you, Mr. Chairman. I yield to the gentlelady from Illinois.
Thank you very much. I just wanted to point out that it was a task force of the NAIC, not the full National Association of Insurance Commissioners, which narrowly voted to approve a resolution to recommend that Congress approve state requests for adjustments or some portion of agent broker commissions as quality expenses. And the full NAIC did vote to count commissions as administrative costs, and most insurers are meeting the MLR with commissions included. So it does seem to be working. Thank you for yielding.
Does anyone else seek recognition? Strike the last words. If not, are there any bipartisan amendments to the bill? Are there any amendments to the bill? The question now occurs on favorably reporting the Access to Professional Health Insurance Advisors Act of 2011. All those in favor shall signify by saying aye.
Aye.
All those opposed, no.
No.
The ayes have it, and the bill is favorably reported. All right, let's go to the chair now calls up H.R. 6118 and asks the clerk to report.
H.R. 6118, to amend Section 353 of the Public Health Service Act with respect to suspension, revocation, and limitation of laboratory.
The first reading of the bill is dispensed with. The bill will be open for amendment at any point. So ordered. The chair moves to strike the last word. H.R. 6118, taking essential steps for testing, the Test Act of 2012, would give the Centers for Medicare and Medicaid Services much-needed regulatory flexibility to enforce prohibitions against improper referrals of proficiency testing under the Clinical Laboratory Improvement Amendments. In order to operate as a business, laboratories must adhere to CMS procedures for processing samples, must share testing results with CMS periodically, and are prohibited from intentionally referring testing samples to any other lab. Currently, the Centers for Medicare and Medicaid Services is required under statute to revoke the CLIA certificate of any laboratory that intentionally refers to its proficiency testing samples to another laboratory for testing for a period of 1 year. In addition, the statute requires that a person who has owned or operated a laboratory which has had its CLIA certification revoked, including those owning multiple labs, may not own or operate a laboratory for a period of 2 years following such revocation. However, there have been instances where a hospital or independent laboratory has accidentally referred a PT sample to another lab due to mistakes by employees or through automated systems. In such instances, CMS is not allowed by law to consider the circumstances under which the test was intentionally referred, or if the lab acted in good faith to report and address the incident. H.R. 6118, Taking Essential Steps for Testing Act, 2012, would address this issue by amending Section 353 of the Public Health Service Act to allow the Secretary discretion to determine whether the 1-year ban on laboratories should be applied, and the flexibility to levy intermediate sanctions instead of the 2-year prohibition against ownership or operation of a lab. I urge members to support the bill. Are there any? Chair recognizes gentleman Mr. Plone. Strike last words.
Thank you, Mr. Chairman. I support this bipartisan, sensible bill that will provide the Centers for Medicare and Medicaid Services, the CMS, with flexibility in imposing penalties on clinical laboratories under the Clinical Laboratory Improvement Amendments of 1988. CLIA ensures that all labs currently operating in the U.S. must be certified and meet certain quality and safety standards. To maintain certification, they're required to perform proficiency tests which measure the quality and competency of a lab's work and must be performed in-house. If a lab is found to have referred a proficiency test to another lab, the Secretary of HHS must revoke that lab's certificate for at least 1 year, thereby preventing it from participating in Medicare or Medicaid for that period. In addition, the operator of any lab that has had its certificate revoked is barred from owning or operating any certified labs for 2 years. However, current law does not allow the Secretary any flexibility in imposing these penalties for labs that improperly refer proficiency tests, even for unintentional referral. So what we're seeing across the country, including in my state, are situations in which labs are being shut down, potentially affecting patient access and care, even when their actions are not worthy of such a sanction. Meanwhile, as the delivery of health care continues to change, specifically as many providers join together to operate under the same umbrella, entire systems are being shut down because of violations there's only one lab within it. And it doesn't seem fair to me. So this legislation helps address the problem, but let's be clear, the law will still require CMS to hold bad actors accountable and bans the practice of PT referral. However, now CMS would be allowed to impose lesser sanctions, if at all, for unintentional PT referrals. So, Mr. Chairman, I thank you and the sponsors for moving this bill. I think it's a common sense reform to CLIA, and I'm pleased to support it.
Chair, thanks, gentlemen. Anyone else seeking recognition? If not, are there any bipartisan amendments to the bill? Are there any other amendments? The question now occurs on favorably reporting the Taking Essential Steps for Testing Act of 2012. All those in favor shall signify by saying aye. Aye. All those opposed, no. The ayes have it, and the bill is favorably reported. The chair now calls up H.R. 1063 and asks the clerk to report.
H.R. 1063, to amend Title 18 of the Social Security Act with respect to the application of Medicare secondary payer rules for certain claims.
Without objection, the first reading of the bill is dispensed with, and the bill will be open for amendment at any point so ordered. The chair now recognizes Dr. Murphy for the purpose of offering an amendment in the nature of a substitute and asks the clerk to report the amendment.
Amendment in the nature of a substitute to H.R. 1063 offered by Mr. Murphy of
Without
Pennsylvania.
objection, the reading of the amendment is dispensed with. Dr. Murphy is recognized for 5 minutes in support of his amendment.
Thank you, Mr. Speaker. The enactment of this bill here, 1063, is meant to work towards solving a problem with Medicare. When a person has a case whereby they may have been injured and there is a settlement on that, Medicare, of course, may have paid the original medical bill, but they want, obviously, to be repaid, and that is only fair. But unfortunately, a major glitch in the system is one that has prevented that from happening. And Medicare basically doesn't tell the attorneys involved or those involved in the case of how much they are owed until there is a settlement, but there's not a settlement until they can find out how much Medicare wants back. It's an unfortunate circular argument which can be easily solved by this bill. It is one that has been worked on with people from both sides of the aisle, as I mentioned earlier, and I thank them all for that. And it's one that unfortunately has had a number of tragic times when we've heard heartbreaking stories about citizens who were owed money but have been unable to collect because of the delays at Medicare. Some of them may not know that they are injured and receive a settlement and don't know that Medicare is supposed to be paid back. We've had cases of people being denied coverage for medical treatment because of the bureaucratic errors. We've heard of people who have had their Social Security checks unfairly garnished, and oftentimes Medicare isn't even accurate. Under the current law, which is the Medicare Secondary Payer Act, insurers, retailers, third parties have to repay Medicare if their negligence leads to medical bills for a senior citizen, but the system is so complicated that we've seen some tragic times even when someone has a situation where they have an unrelated injury years later, an unrelated disease, such as a woman who had a chest injury and years later had breast cancer, and Medicare was refusing to pay for her treatments because, according to their paperwork, there were problems there. So this SMART Act requires Medicare to provide the parties with accurate information about the total cost of medical bills when a plaintiff and defendant agree to settle an injury claim. Simply put, this legislation aims to break down those bureaucratic hurdles that prevent Medicare and private insurers from closing up medical bills cases in a timely manner. If the parties don't have that claims information, they can't reach a settlement, and Medicare can't recoup the money, and beneficiaries are often left footing the bill. And let me add, this sends money back to Medicare. Industry experts have suggested that my bill could collect between $1 billion and $4 billion annually owed to the trust fund, while saving Medicare agency countless hours of staff work pursuing claims that sometimes have little or no value, and quite frankly, sometimes claims that have value of under $1. Here's how it works. If a Medicare recipient gets in a car crash or injured by a defective pacemaker, the government picks up the hospital tab. But if that person receives a payment from a legal settlement, insurance policy, or jury award that covers accident-related medical bills, Medicare is entitled to its money back. In the private sector, health insurers and auto insurers routinely resolve these matters painlessly. And in that situation, the insurer would get their money back and the plaintiff would collect their settlement. All's done. But now with this. So this solves a problem that's been around for a while. It brings money back to Medicare. A few billion here and there adds up, and sometimes we're talking about real money. But the most of all, this really gives some of the seniors a peace of mind so that they're not hounded and have their Social Security and their pension funds garnished for this. So I ask all members to support this bill. And again, I thank everyone from both sides of the aisle and staff for working so hard on this bill. With that, I yield back.
Chair, thanks, gentlemen. Is there any other discussion of the amendment? Recognize Mr. Colon for 5 minutes.
Thank you, Mr. Chairman. I'm pleased the committee is considering H.R. 1063, the Strengthening Medicare and Repaying Taxpayers Act of 2011. This legislation is an important step in addressing issues that have arisen under the Medicare secondary payer process. I'd like to thank the sponsors of the bill as well as Chairman Pitts for working with us in a bipartisan way to improve the bill. In 2008, Congress expanded and strengthened the Medicare secondary payer program, and while good intentioned, the Centers for Medicare and Medicaid Services, CMS, and stakeholders have struggled with the changes. This bill would address a number of concerns relating to the certain group health plans, GHP, and non-group health plans, NGHP, as well as auto or other liability insurance, no-fault insurance, and workers' compensation plans that are subject to MSP rules. While CMS has implemented a number of helpful changes in response to stakeholder input, it's clear that more needs to be done to help further smooth the process. This legislation would ensure beneficiaries can get needed information to expeditiously reach settlement It also would have CMS establish a nuisance threshold for all claims, which means they shouldn't be chasing $5 claims if it costs CMS $100 to recover that money. The bill also improves the reporting and penalty provisions and clarifies the statute of limitations. The bipartisan work to the bill is contained in today's amendment in nature of a substitute and represents strong improvements to the original bill. We've worked out the key issues, and while we await some feedback from CBO and CMS, I'm hopeful we can continue to work together over the next week as we move toward full committee markup on any outstanding items. And so I urge my colleagues to support the legislation. And I would yield to yourself?
Yeah.
To the chairman.
All right. The Energy and Commerce Committee held an oversight hearing on June 22nd, 2011 to review the program. Witness testimony reported that flaws in the program resulted in beneficiaries receiving demands for large amounts of money that they did not owe or could not pay, and losing Medicare coverage due to improper actions by contractors. In addition, Medicare's inability to produce a final demand of repayment letter in a timely manner often resulted in beneficiary settlements being placed in escrow, a needless delay in making seniors whole. H.R. 1063 seeks to address these problems by making several improvements to the MSP statute, including facilitating final payment amounts from Medicare in order to speed up the settlement process and prevent senior settlements from ending up in escrow. I would like to thank Dr. Murphy for his leadership on this issue, and Mr. Waxman and Mr. Pallone for working in a bipartisan manner to present H.R. 1063 to the committee today, and urge my colleagues to pass the legislation. Is there anyone else seeking recognition? If not, are there any bipartisan amendments to the amendment? Are there any other amendments? If there are no other amendments, the vote occurs on the amendment in the nature of a substitute. All those in favor shall signify by saying aye. Aye. All those opposed, no. The ayes have it, and the amendment is agreed to. Are there any further amendments? The question now occurs on favorably reporting the Strengthening Medicare and Repaying Taxpayers Act of 2011 as amended. All those in favor shall signify by saying aye. Aye. All those opposed, no. The ayes have it, and the bill is favorably reported. All right. The chair now calls up H.R. 6163 and asks the clerk to report.
H.R. 6163, to amend Title IV of the Public Health Service Act to provide for a national pediatric research network.
Without objection, the first reading of the bill is dispensed with, and the bill will be open for amendment at any point. So ordered. Does anyone seek recognition to speak on the bill? Where's Kathy? Or, yeah, who? The chair recognizes the gentlelady from California, Ms. Capps, for 5 minutes.
Mr. Chairman, I move to strike the last word. And thank you, Chairman Pitts and Ranking Member Pallone, for bringing up this bill for markup today. The National Pediatric Research Network Act is an important bill to improve research and clinical trials on pediatric diseases, to train future pediatric researchers, and to disseminate research findings quickly so that all children may benefit. And it will add important resources and capacity to research children's rare diseases like spinal muscular atrophy, SMA, and to develop new treatments to fight them. I'm proud to have co-authored this legislation with my friend, Congresswoman Kathy McMorris Rogers. And I'd like to recognize our colleague, Congresswoman Diana DeGette, for her leadership on this issue over the years. And finally, I would especially like to thank my constituents, Bill and Victoria Strong, for their tireless work on behalf of their daughter, Gwendolyn, and all children with spinal muscular atrophy and other rare diseases. And it's quite noteworthy, I believe, that Gwendolyn just began kindergarten at a public school in Santa Barbara. This family and others have shown how entire communities can come together to fight diseases like SMA. I'm so hopeful that in a similar way we can continue our bipartisan work together on this in this committee and in the House as a whole to move this important legislation to the House floor. I urge my colleagues' full support for this measure, and I yield back.
Would the gentlelady yield?
I'll be happy to yield to you.
Sure, thanks, gentlelady. Pediatric research is so important to the health of our children, yet we continue to struggle with unmet needs. By establishing pediatric research networks and consortia, this bill will improve research by coordinating research efforts among participating institutions. Consortia will be invaluable for children's health by focusing on the most pressing needs in pediatric rare diseases. And I want to thank both Ms. McMorris-Rogers and Ms. Capps for their work on behalf of children in need. And with that, I yield back. Are there any bipartisan amendments to the bill? Are there any other amendments? The question now occurs on favorably reporting the National Pediatric Research Network Act of 2012. All those in favor shall signify by saying aye. Aye. All those opposed, no. No. The ayes have it, and the bill is favorably reported. The chair now calls up H.R. 4124 and asks the clerk to report.
H.R. 4124, to amend the Public Health Service Act to provide grants to states to streamline state requirements and procedures for veterans with military emergency.
Without objection, the first reading of the bill is dispensed with, and the bill will be open for amendment at any point. So ordered. The chair now recognizes himself to offer an amendment, and the clerk will report the amendment.
Amendment to H.R. 4124, offered by Mr. Pitts of
Without
Pennsylvania.
objection, the reading of the amendment is dispensed with. I'd like to recognize myself to speak on the amendment. As established by House rules, any new bill which authorizes the appropriations of funds for a new program shall include language offsetting the full value of such authorization with a reduction in the authorization of current ongoing spending. H.R. 4124 is a new program that will cost $1 million over 5 years. That cost will be offset by the Area Health Education Center program that is authorized in Section 751 of the Public Health Service Act. AHEC programs and centers are authorized at $125 million until 2015. This offset will not prevent AHEC from moving forward with its important work in addressing healthcare workforce shortages. I want to thank Mr. Kinzinger and Ms. Capps for their work on this bill and urge all members to support the amendment and final passage of H.R. 4124. Is there further discussion of the amendment? Chair recognizes gentlelady. What?
I think she wants to speak on the bill, so pass the amendment. We can speak on the bill.
On the bill, okay. Is there further discussion on the amendment? All right. If there's no further discussion, the vote occurs on the amendment. All those in favor shall signify by saying aye. Aye. All those opposed, no. The ayes have it, and the amendment is agreed to. Okay. Does anyone wish to speak on the bill? Chair recognizes the gentlelady from California, Ms. Capps, for 5 minutes.
Thank you, Chairman Pitts and Ranking Member Pallone, for bringing this bill for markup today, and I appreciate the amendment and support it. And I want to thank also the staff on both sides of the aisle for working very hard to find a bipartisan pay-for to keep it moving forward. I know this feeling is shared, that our military medics serve our nation with great distinction. They receive some of the best technical training in emergency medicine, and they prove their skills on the battlefield every day. But for far too long, artificial barriers have kept these talented professionals out of the civilian first responder workforce when they return home from the field of battle. And that's why efforts like the Veteran Emergency Medical Technician Support Act and my bill, H.R. 3884, the Emergency Medic Transition Act, are very much needed. They are important steps toward ensuring that our military medics can translate their skills and their experience into civilian service here at home. I'm very pleased to have joined Congressman Adam Kinzinger to introduce this bill, and I'm hopeful that we can continue to work together in a bipartisan way to move this important legislation to the House floor. I'll just want to mention parenthetically that just last week, I was in a small coastal community in California, my district, Morro Bay, meeting with the Chamber of Commerce, and they wanted to know what kind of legislation I had brought up, and I mentioned this bill, and afterwards, 2 veterans who happened to be members of the Chamber of Commerce came up to me and they said, we're astonished that this hasn't already happened, and it's such a good idea. So you can be sure this will be met with bipartisan support out in our communities in wherever they are in the country. So I urge my colleagues full support for this measure. And if if anyone else wants to speak, I'll be happy to yield. Otherwise, I will be prepared to yield back.
Chair thanks the gentlelady. Are there any other amendments? Does anyone else wish to be heard on the bill? Okay, the question now occurs on favorably reporting H.R. 4124 as amended to the full committee. All those in favor say aye. Aye. Those opposed, no. The ayes appear to have it. The ayes have it, and the bill is favorably reported. The chair now calls up H.R. 733 and asks the clerk to report.
H.R. 733, to amend the Public Health Service Act to provide for a pancreatic cancer initiative and for other purposes.
Without objection, the first reading of the bill is dispensed with. The bill will be open for amendment at any point. So order. The chair recognizes Mr. Lance for the purpose of offering an amendment in the nature of a substitute. Ask the clerk to report the amendment.
Amendment in the nature of a substitute to H.R. 733 offered by Mr. Lance of
Without
New Jersey.
objection, the reading of the amendment is dispensed with, and Mr. Lance is recognized for 5 minutes in support of his amendment.
Thank you, Mr. Chairman. This amendment will expand the focus of the bill to recalcitrant cancers, which are cancers that have high mortality rates and have not seen substantial progress in diagnoses or treatment. The bill, which will be retitled the Recalcitrant Cancer Research Act of 2012, will direct the National Cancer Institute to establish a scientific framework that will guide research efforts on recalcitrant cancers by identifying unanswered medical and scientific questions. The scientific framework will include a review of the current literature, identification of relevant scientific advances and well-qualified researchers, a list of initiatives and partnerships that can advance coordination of research, and research resources such as patient registries and tissue banks. Information on the implementation of the scientific framework will be included in the NIH biennial report. Since the war on cancer was declared more than 40 years ago by President Nixon, the overall 5-year survival rate for all cancers has climbed from approximately 50% to 67%. However, there are still cancers that have yet to reach the 50% benchmark and are, of course, the deadliest cancers of all. For example, pancreatic cancer has a 5-year survival rate of only 6% and is the 4th leading cause of cancer death in the United States. It is cancers like this that the bill will seek to address. I recognize the hard work that my colleague, Congresswoman Anna Eshoo, has put into this effort, as well as the staffs of Chairman Pitts and Ranking Member Pallone. I urge all of my colleagues to support the amendment, and I yield back the balance of my time.
Gentlemen, yield?
Yes, of course.
It is never easy to lose someone to cancer, but it is especially difficult when you're not given a fighting chance. Recalcitrant cancers, with their low survival rates and poor outcomes, have baffled researchers for decades. This bill will provide a way to coordinate and focus the fine efforts at the National Cancer Institute to improve prevention, diagnosis, and treatment of hard-to-treat cancers, like pancreatic and ovarian cancer, and hopefully save lives. And I want to thank Mr. Lance and Ms. Eshoo for their hard work on the bill. With that, I'll yield back. The chair now recognizes gentleman Mr. Pallone for 5 minutes. Strike the last words.
Thank you, Mr. Chairman. I'd like to convey my support for the Lance amendment. This amendment is the result of hard work by members and staff on a bipartisan basis to address the policy goals of H.R. 733. The amendment calls on the director of the National Cancer Institute to develop, in consultation with expert working groups, scientific frameworks to guide research on recalcitrant cancers. These are cancers that have often referred to as the deadliest cancers, meaning they have a high mortality rate but have not seen substantial progress in the diagnosis or treatment of the disease. Deadliest cancers have a 5-year survival rate of less than 50%. They include ovary, brain, myeloma, stomach, esophagus, lung, liver, and pancreas. Combined, these deadly cancers make up half of all cancer deaths. And Mr. Chairman, pancreatic cancer is very personal for me. In the spring of 2008, my mother was diagnosed with pancreatic cancer, and she passed away late that same year. Unfortunately, only 6% of people diagnosed with pancreatic cancer live longer than 5 years, and that number has remained relatively unchanged in the last 40 years since the passage of the National Cancer Act. Pancreatic cancer is different from other cancers due to a shell-like barrier that the tumor builds around itself, limiting blood flow and making it difficult to deliver drugs to the tumor. In addition, there are no early detection tools or good therapies for pancreatic cancer. So that's why my colleagues Anna Eshoo and Leonard Lance introduced the original bill, which would have specifically addressed the large gap of discovery and progress for pancreatic cancer. This new language would still establish a structure for NCI to take a closer look at pancreatic cancer, but it now includes other types of cancer with high mortality rates. I believe this amendment represents an important step forward in identifying and answering critical scientific questions for these forms of cancer, and I want to commend the work of my colleagues and the staff, and I look forward to its progress in this committee. Thank you, Mr. Chairman.
Chair thanks the gentleman. Is there any further discussion on the substitute amendment? Are there any bipartisan amendments to the amendment? Are there any other amendments? If there are no more amendments, the vote occurs on the amendment in the nature of a substitute. All those in favor shall signify by saying aye. 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 All those opposed, no. The ayes have it, and the amendment is agreed to. Are there further amendments? The question now occurs on favorably reporting the Pancreatic Cancer Research and Education Act of 2012 as amended. All those in favor shall signify by saying aye. Aye. All those opposed, no. The ayes have it, and the bill is favorably reported. Without objection, staff is authorized to make technical and conforming changes to the bills approved by the subcommittee today. So ordered. Without objection, the subcommittee stands adjourned.